Well, happy June 2nd, everybody. Here we are with our monthly Ask the Doc series. We appreciate you taking time to join us. We today have chosen the topic of articular cartilage damage and ways that we treat that in our clinic. I'm joined by my colleague, Dr. Annette Ombach, and I'm Dr.
Hi,
Chris
everyone.
Rogers. Yep. And Dr. Ombach and I are board certified physical medicine and rehabilitation physicians, fellowship trained in sports medicine and pain management. And Dr. Ombach is board certified, fellowship trained in regenerative medicine, which is the new field that we are talking about today. Scientists have figured out how our bodies heal themselves, and now doctors are figuring out how to use that technology as a form of new treatment for common orthopedic conditions. And probably one of the most common things we see in our clinic would be injury to the articular cartilage. So Dr. Ombach, what is articular cartilage?
Thank you for asking that question. Before we start answering your questions about articular cartilage, we want to define what cartilage is, right? So it is the lining of the joints where your bones meet, and it provides a cushioning support and a lubricating mechanism whereby your joints can freely move. There are different kinds of cartilage. There's hyaline cartilage, there's elastic cartilage, there's also fibrous cartilage. But we're talking about hyaline cartilage for joint, which is the most common kind of cartilage that we have in our body. And this is a pretty unique structure because it has the ability to give you structural support, but at the same time, also a flexible in order for your joints to be able to move freely. The cartilage doesn't have blood supply, doesn't have nerve innervation, doesn't have lymphatic drainage. So it's a quite unique structure. When you have cartilage injury, you start feeling pain not because you have injury to the cartilage itself, but when it starts affecting the surrounding tissues in your joint or surrounding structures in your joint that have pain innervation, like the bone underneath it, or the synovial lining of your joint, or the joint capsule. And that's when you start having pain. There are different causes of cartilage damage. The most common, of course, is osteoarthritis. And osteoarthritis is a condition whereby the cartilage is damaged by a different mechanism. But what happens is that there's this chronic inflammation that happens in the joint that eventually becomes a perpetuator of degradation in the cartilage and the other tissues in the joint, creating other changes in the joint that creates decreased joint space, decreased lining or cushion, and inflammation and bone spurs, and eventually pain. There are other causes of joint cartilage damage as well. Dr. Rogers, if you want to add.
Yeah, other causes of articular cartilage damage, there are so many. There are some known diseases such as, say, rheumatoid arthritis, which is an autoimmune condition where your immune system mistakes your lining of your joint for the enemy, thinking that it's a bacteria or a virus, and it starts attacking the lining of the joint. And as Dr. Ombach just said, that lining of the joint, which we call the synovial tissue, is filled with immune cells. So white cells, for example, monocytes, macrophages, and these cells, which are normally designed to damage bacteria and viruses, accidentally start damaging the lining of the joint, causing further inflammation, and that the molecules that are produced by those cells actually causes damage to the cartilage. It's actually important to recognize the fact that our bodies are constantly growing, constantly healing. Even as we sit here, as we speak, our bone marrow is making billions and billions of red cells and platelets and white cells, and our cartilage is growing too, but much, much slower. There aren't very many cells in the cartilage. There isn't a very good blood supply, as Dr. Ombach mentioned. And so it's very easy to throw the balance out of balance. So if on the one hand, you have these cartilage cells trying to make new cartilage, And at the same time, you have all this damage occurring to your body, either by physical trauma or by chronic inflammation with these molecules eroding away at the cartilage. If that becomes out of balance, there'll be a net loss of cartilage, just like with osteoporosis, where you're growing bone all the time, but at the same time, your body is resorbing bone. If that's out of balance, you'll have a net loss of bone. Your bones become brittle. So if your cartilage becomes brittle and soft, it can start to tear and flake off. And so there are many other causes. You may have heard of something called gout, where your body makes too much uric acid. That also promotes inflammation. The uric acid crystals are actually like little shards of glass. They can cause damage to the cartilage tissue. There's something called pseudogout, where your body can produce other types of minerals which are harmful to the cartilage. But the most common condition by far, what we see, is that osteoarthritis, where you may have had some injury to your knee at some point in your life. You were playing soccer when you were 12, or fell off your bike or something and had a little ding in the cartilage. And this starts the whole process of osteoarthritis, where the cells start to function abnormally. And not only can the immune system cells attack your cartilage, but the cartilage cells themselves can attack themselves. They produce molecules that are toxic to themselves. And so understanding that is critical to understanding how these new treatments work, how we reverse those processes.
That's right. So Dr. Rogers alluded to trauma, which is another cause of cartilage damage. The trauma itself can initiate that cartilage injury, but it can also lead to a condition that's called post-traumatic osteoarthritis or arthritis. There are also, although rare, genetic disorders that can cause abnormal cartilage synthesis, which can cause eventually problems with joint functioning. There's also there's a lot of different kinds of inflammatory arthritis, like Dr. Rogers has alluded. It could be because of lupus or rheumatoid arthritis, or the crystal deposit diseases that Dr. Rogers was talking about. There's also a condition that's called osteochondritis dissecans. I actually saw a young patient last week who had this condition. But basically what happens is there's an abnormality in the cartilage, in the bone underneath the cartilage, that eventually creates some cartilage damage. And we see this most commonly in young athletes, especially the throwing athletes, wherein we see some damage to the cartilage in their elbow joint and into the bones surrounding the elbow joint. We also see it in the ankle and in the knee. But this is a multifactorial in cause. It could be repetitive trauma. It could be because of inflammation. It could be because of decreased blood supply, or a hereditary cause as well. So lots of reasons why the cartilage can be damaged. So let's go to one question here with regards to osteoarthritis. The sports medicine doctor this morning said continuing deterioration of the knee, perhaps cartilage. Is it possible to treat this even though I had previous treatment? This patient had a prior treatment with lipogems 3.5 years ago. And she had great success, but it looks like about a month ago, the pain is starting to return. And she is asking if she can treat this again, even though she had the prior treatment.
Oh, so much to talk about there. So yes, lipogems is an FDA-approved device, is the best way to characterize it. It is a device that allows your doctor to collect cells from the fat. Usually this is done through a liposuction procedure in the office. Those cells, of which there are many different kinds. One kind, of course, is the adipose-derived stem cell, or the mesenchymal stem cell. Goes by many different names, unfortunately. But there are other cells in the fat that have been shown to be helpful for decreasing the pain and inflammation of osteoarthritis, and even to help with new cartilage growth. The challenge is, challenges are many. First of all, we're all getting older all the time. So our ability to heal spontaneously diminishes as we age. Most of the patients that we've treated with lipogems are older. On average, they're 65 to 70 years of age, typically. Many of them will have severe osteoarthritis. Some of them may have ligament tears or tendon tears in addition to the cartilage damage. And the procedure is actually quite simple. The procedure involves collecting the cells from the fat, using this FDA-approved device to rinse and wash the fat. And then that fat is injected directly into the joint. We use ultrasound guidance, of course, so we can see where we are injecting. And usually over the course of 2 or 3 or 4 months, the patient will notice that the pain is less, the inflammation is decreased, they can walk better. We combine this, of course, with physical therapy because most of our patients are severely deconditioned because of their arthritis. So there's some strengthening required. But unfortunately, nothing lasts forever. And so we're finding that, I've been doing this treatment on my patients for about 7 years. I was one of the first in the United States to actually do this procedure. It's looking like many people, the effects start to wear off around that 4-year period. So, which is quite good to think that you can get 4 years of relief from a single shot. But the problem is repeating it is expensive and there's, it's involved. So it takes time to do the procedure. So it can be repeated. We've had a few cases where we have repeated it with good results. We've had a few cases where we've actually demonstrated cartilage growth on MRI. There's a couple of published papers that conducted by our colleagues that also showed improvement in cartilage health after this treatment. And I would characterize it this way: the science is continually evolving. We think the future will involve a single collection of the adipose tissue. So you only have to go through one liposuction procedure, and then we'll treat you. But we'll take a little bit extra. Nobody really worries about having a little extra fat taken out. And that fat can be stored and frozen and then used again at a later date. And we think that fat can survive in the freezer for about 10 to 20 years, perhaps longer. So this way you could have a repeat treatment, 3 to 4 years down the road. So this might be an option.
There are 3 different cell therapy treatments that we do in the clinic to answer this next question.
Okay.
There's platelet-rich plasma, which we call PRP. That's the most common cell therapy that we use to treat joint osteoarthritis or articular damage, and that involves obtaining blood from your veins and processing that blood to get a very concentrated amount of platelets. And these platelets are the ones that has thousands of growth factors that are involved in healing and repair of your joint damage. And the other type of cell that we use is what Dr. Rogers was alluding to, which is the mesenchymal stem cells, which are derived from either your fat using the LipoGems device or from your bone marrow. And both of these tissue sources have their strengths and they're indicated for certain conditions. But with regards to PRP, we typically use this for mild to moderate joint damage or joint arthritis. But when your arthritis becomes moderate to severe, then we tend to favor the therapies that are derived from either your bone marrow or from your fat cells.
Right. And we get this question a lot. What's the difference between PRP, which involves the platelets from your blood, versus a stem cell, what we would call a stem cell treatment, but more accurately is a multicellular treatment, because whether we take the cells from the fat or whether we take the cells from the bone marrow, it's not just stem cells. As a matter of fact, in the bone marrow, less than 0.1% of the cells are stem cells, at least this type of stem cells that we're talking about, the mesenchymal stem cells. There are other stem cells in there, and there are lots of platelets, and there are a lot of other molecules. And so it's really a mixture, a soup. So if you ever hear a doctor say, well, I do stem cell therapy using bone marrow, well, you can tell them you're not really doing stem cell therapy. You're doing bone marrow therapy, which has been shown to be effective. And we've had many cases where we've treated patients harvesting the bone marrow. The bone marrow quality is a little bit better when you're younger. So if you're maybe 50, 55 and younger, the bone marrow might be a better option. As you get older, the fat will probably be a better option for those patients. And we've had very good success, more than 92% response rate in the case of the LipoGems cases that we have documented and published on. But the The effect, the question that we get is, can stem cells grow cartilage? In the lab, absolutely they can. In animal models, absolutely they can. In humans, probably they do, but not all the time. We think that there's more to it. We don't think it's just a matter of growing cartilage, but we think it's a matter of decreasing inflammation, decreasing pain. The stem cells actually can do many, many different things that are beneficial for that arthritic joint.
That's right. There has been studies in humans showing before and after MRI studies that have shown improvement in the cartilage content, in the cartilage thickness, improvement in the cartilage quality, as well for both PRP and cell-based therapies. So we know that these cells are doing something to your joint with regards to improving your cartilage, but also all the other things that Dr. Rogers has mentioned with regards to maintaining your joint health.
And speaking about joint, if I could interrupt just a second,
Yeah.
I see there's a couple of questions about joint health related items, and there are many things that improve the health of your joint. Pretty much anything that improves the health of your body will improve the health of your joint. So obviously getting sleep. Why? Because when you sleep, that's when your body produces all the important growth hormones that stimulate healing in your body. It also decreases inflammation in your body. Did you know that? Getting a good night's sleep actually decreases inflammation in your body. And you know that because when you don't get a good night's sleep, especially if you stay up late eating ice cream and something else, I don't know, the next morning you don't feel as well because you have all these inflammatory molecules floating around in your body. Just like when you have the flu, you have all these inflammatory molecules floating around in your bloodstream and you feel terrible. It's not the flu virus making you feel terrible. It's your own immune system telling you, you feel terrible, you're infected, go lie down, get some rest. Let's get this inflammation under control. The exact same thing happens when you get a bad night's sleep. So sleep is important. Nutrition, of course, there are foods that we know that cause inflammation, right? We know that, foods that are high in sugar content, dairy, things like this. For some people, they're sensitive to certain foods, wheat products, etc. We know that this causes inflammation. Whether or not that causes inflammation in the actual arthritic joint, I think is yet to be determined, but I think it's probably safe to say that there is some correlation. And so things that you can do to decrease inflammation other than eating healthy plants and fruits and veggies and lean meats and these kinds of things would be the supplements that people talk about. So one person asked about turmeric, which is also called curcumin, which is an anti-inflammatory molecule that has been shown to be effective for decreasing pain, decreasing inflammation in the cases of osteoarthritis. So we do recommend turmeric. Unfortunately, the actual dose has not been well studied, so it might differ for different folks, but generally twice a day is usually sufficient for the standard dose that you would see. And these are over the counter, by the way. Bromelain, boswellia, cat's claw, all these supplements have been studied and have been shown to be helpful for decreasing inflammation. And then paradoxically, exercise. So a lot of times people are confused when we tell them that it's good to walk on that arthritic knee. As long as it's not causing too much pain, as long as your knee is not horribly unstable or horribly damaged, walking actually does stimulate cartilage to grow. So all the things that you would expect: good sleep, good nutrition, good exercise, good for your joint.
If you want to learn more about natural supplements and joint therapies, we actually did a webinar with one of our local naturopathic doctors who's also a medical doctor. And you can see that in our YouTube channel where we keep all our webinars and also a recording of this Ask the Doc series. All right, there's a question here with regards to the testing that one can do to determine whether the joint issues is arthritis and the source of it. So after the evaluation and the physical exam, there's different tests that we can do to determine what's causing your joint cartilage damage. There's imaging studies, and that could be an X-ray study, an MRI study, or an ultrasound study, and this can give us some window to the structural damage that's occurring in your joint. There are some testing that we can do with regards to testing the fluid in your joint to check if there's any inflammatory the chemicals in there, or if there's a crystals in there that can cause gout or the other kind of crystals that can cause pain. There are some blood tests that can test for specific genetic conditions, or inflammatory markers that are suggestive of systemic inflammation like lupus or rheumatoid arthritis or other seronegative spondyloarthropathies or more of an autoimmune condition. So the testing is designed on depending on what we get from your history and the physical exam. So not everybody gets all these tests all at the same time, but it just depends on what we think is the most likely diagnosis.
Yeah, that's right. Every patient really is unique. And so our approach might vary depending on what symptoms you're having and what we're most suspicious of. I'm finding that I'm ordering a lot more tests. You know, a lot of doctors will simply order an X-ray. I'm finding that I'm ordering a lot more MRIs and doing ultrasound as well, because I'm finding things on those additional tests that maybe were missed on just a simple X-ray. And so, especially when we approach a knee from a regenerative medicine perspective, it's one thing to inject those cells into the joint to improve cartilage health and decrease inflammation inside the joint. But many of these patients also have chronic ligament tears or tendon tears, which are outside the joint and need to be treated as well. And you wouldn't see that obviously on an X-ray, but you might see that on an MRI. And on some cases, you even see it better with the ultrasound, which we can do right in the office.
Right. All right. So we've got about 5 questions to answer in the next 5 minutes, Dr. Rogers. I'm
Okay.
gonna go through all this. Next question: when should we consider PRP or stem cell therapy in the recovery process? They're asking about a sweet time when you injured yourself and when's the best time to do the cell therapy.
Oh, I see. Well, it depends on the injury, of course, but there's different kinds of injuries. So there's, you know, osteochondral defects. So you have injury to the cartilage and the bone, or you have an injury to the ligament. Um, Generally, you know, we let Mother Nature take her course. Mother Nature is pretty good, you know, so usually it's a minimum 6 to 8 weeks of rest, physical therapy, you know, protecting the joint and seeing how far we can get to relieve the pain and to um, improve the function. If we haven't achieved our goals by that time point, that's when we might start to consider regenerative medicine. Now, you may say, well, gosh, what about prevention or what about early treatment? I think the reason why I'm a little cautious to offer that at this point in our history is we don't have a lot of data to suggest that it alters the course. So if we have a study that said, well, gosh, if you throw those cells in 2 weeks after the injury and patients get better in half the time, well, then absolutely we're going to do that. But that data is not there yet. So really we're using regenerative medicine at this point for patients who just are not getting better with more traditional standard care.
Can you do these procedures in the shoulder? I'm 49 and I'm looking at total shoulder replacement. I'm sorry to hear that. You're pretty young to have a total shoulder replacement at 49.
Yeah.
Unfortunately, we see this in the clinic. We have done these therapies in the knee joint most commonly, but we have also done it in the shoulder joint, in the hip joint, and in the ankle joint, and even in the small joints in your thumbs and in your hand. So yes, we have seen success with using these therapies for big joints in the body and also in the small joints in the body.
There's actually I've done dozens of I've treated dozens of shoulders of this severity. They're generally more difficult to treat. The success rate's not as high, but it's still better than 50%, which is a coin toss, and it's certainly better than the standard of care, which would be cortisone and some of the other, even the hyaluronic acid injections, I don't find as effective as some of the things we've been doing. But just be forewarned, if you're looking at total shoulder, then you have very severe shoulder arthritis, and those are going to be a little bit more challenging, but we have had success in those cases.
Right. So just very quickly, because there's a question here about HA. HA is hyaluronic acid injection, and this is a gel viscosupplementation that is injected to your knee that helps, or into any joint in your body, that helps decrease inflammation. It also helps provide mechanical support. The advantages of this is it doesn't have the side effects of cortisone, wherein it can degrade cartilage. The disadvantage of this treatment is it's short term, just like cortisone. It lasts for maybe 4 months, maybe 6 months at best. And it doesn't do anything to alter or improve the arthritis that has set in your joint. So it's a temporary treatment that probably has less side effects than cortisone. It used to be that insurance covers for these procedures, but now they have stopped covering for it. I think only Medicare is covering for certain conditions in the knee. But otherwise now it's all not covered by insurance.
And there's also good evidence that the high molecular weight hyaluronic acid is more effective for knee arthritis and other forms of arthritis than the low molecular weight. And I don't know if there are many doctors that still use the low molecular weight, but it might be a question to ask your doctor. If your doctor's recommending an HA gel injection, just say, hey, is it high molecular weight? You'll really improve them. You'll really impress them. I mean, high molecular weight, HA, that's what I want. But even still, the data shows that 6 months at best. I have had a handful of folks who say they get a year's relief out of it, but it's by far the minority.
That's correct. All right, there's a question here about fracture. Address your thoughts on PRP for trimalleolar fracture in the ankle for an athlete in their early 40s.
Again, yeah.
Early patient, 40-year-olds having a lot of injuries here.
Yeah.
Any comparison to stem cell injections and expense?
No data is the first response. No published data. So take everything we say with a grain of salt. That kind of injury is a significant injury. Usually those patients are looking at some kind of surgical intervention in my experience. However, if it's mostly healed with just one area that's maybe a non-union where we've had some success, not in that particular part of the body, but in other parts of the body where there was a fracture that wouldn't heal using bone marrow aspirate. And there's a number of published papers on that as well. Dr. Hernigau, who we've talked about on this webinar series before, an orthopedic surgeon in France, has published a number of papers on the use of bone marrow aspirate concentrate for fractures that just won't heal otherwise, and the results have been very good.
That's right. All right. If you have time,
one more question.
This is we're talking about different kind of cartilage in the spine, which is the disc. It says, I have a protruding disc at L45 causing sciatica. Can your procedures help avoid the horrible S words?
Yeah, as somebody who suffers from herniated discs, I feel your pain. I would say it depends on the disc. They're all different. Usually the ones that are in the 3 to 4 to 5 millimeter range do better. The ones that get close to 1 centimeter in size, in my experience, generally do require surgery. I agree, nobody wants surgery, but I will have to tell you that this is one of those cases where I think spine surgery is a good thing. I think there's so many folks that suffer needlessly with a large herniated disc, sciatica, want to avoid the surgery. The surgery's come a long way in the last decade, and we can get you to we know the top docs in this area if it requires surgery. But yes, we have treated the smaller types of herniated discs with good results, even disc tears that aren't herniating. So that's something that we would evaluate on a case-by-case basis, I would say.
That's correct. A lot of the cell therapy studies on the spine is actually using a treatment for disc degeneration and disc tears. And again, if you want to get more information on this, we have a specific webinar that talks about just all disc degeneration using a bone marrow cell therapy or PRP.
And Dr. Ambach, there's one quick question on bone marrow. A patient had bone marrow aspiration performed in the hip. I'm assuming that was for hip arthritis, and it's been not quite, well, it's been about a year and the pain is coming back. So that's a patient that needs to be reevaluated. There's a reason why that pain is coming back so soon. I will just tell you, we're talking about hyaluronic acid and PRP and bone marrow and fat tissue as if there's only 4 treatments. But in each of those categories, just hyaluronic acid alone, there's probably 24 different types. So in PRP, there's probably 30 different ways to make it. And bone marrow, there's a right way and a wrong way to make it. So it's possible that it just wasn't a high enough dose of cells. And that's another nuance that maybe we should cover in another webinar.
That's a great segue to end this session. So we do this session. This is a live Q&A session, which is a 30 minutes question and answer session that Dr. Rogers and I do every first Wednesday of the month. So you can see us again next month, Wednesday at 12:30 to discuss and tackle another topic. We also do webinars if you want to listen to more detailed lectures about specific orthopedic conditions and regenerative therapy options. Our next webinar will be next month. This month, we will be doing a webinar for physicians to educate them about this regenerative therapy. But if you keep in touch with us through Facebook or through our blogs, YouTube channel, and through Instagram, you can get updates on when our next sessions would be. But every 12:30, first Wednesday of the month, let's do the Q&A and keep those questions coming. Thank you for joining us.
Yeah, thank you for joining us. And if you have a very specific question about your personal health, then feel free to either call us, email us, or just schedule a consult.
Thank you. Have a good day, everyone.
Thank you.